Hi, welcome to this short video explaining some of the innovations in Liverpool as part of our involvement in the ITHACA project. At the end of 2019, Liverpool took part in an ITHACA exchange visit with Slovenia. This helped us to develop plans with our cancer hospital to support patients in their own homes using a type of virtual ward model. However, in March 2020, the first wave of the COVID pandemic hit the UK. And this forced us to change our plans and adapt the project to the challenging times that we now all face. Liverpool were actually fortunate because we already had a well-established telehealth service that had grown up over the last 8 years. This experience in remote patient monitoring means that the local GPs and hospitals are both aware of the service and actually trust it. It also means we have a strong relationship between Liverpool CCG, who fund the service, Merseycare, who operate the clinical monitoring hub, and Docabo, who provide the monitoring system and technology. This enabled the Liverpool team to work together to rapidly scale up the service and address several clinical challenges that COVID presented. To give you an example, before COVID, we were supporting around 2,000 long-term condition patients at a time. Because of COVID, the service was rapidly scaled up to support nearly 4,000 extra COPD patients within a few months. So that was scaling up the service to support nearly 3 times as many patients in about 3 months. In addition to that, we have worked with local hospitals to implement 3 virtual ward type pathways. We'll discuss those innovations in a minute, but first I'll let Peter from Merseycare explain the basic telehealth service.
Hello, I'm Peter Almond. I'm the Cheshire Merseyside Remote Monitoring Programme Manager, and I've helped implement and develop telehealth within the region over the last 7 years. Merseyside has traditionally suffered from some of the poorest health outcomes in England, particularly with regards to deaths attributed to cardiovascular and respiratory diseases. The COVID-19 pandemic has exacerbated these issues and further highlighted the need to deliver services differently through the use of technology. Pre-pandemic, in Liverpool, Merseycare NHS Foundation Trust has been operating a mature telehealth service for several years. Deployed to 13,000 patients and monitoring up to 2,000 patients per day, working in collaboration between community care, primary care and secondary care, and alongside our telehealth provider, Docabo. Over these years, we've laid the foundation that has enabled the service to scale up with relative ease. The telehealth hub has a broad skill mix that includes clinicians, admin and project management, with all the governance and safeguards you'd expect from a large organisation wrapped around the service. This has enabled large cohorts of patients to be monitored at any one time. The hub is very effective at providing monitoring across a variety of clinical pathways that helps contribute to admission avoidance and expedited hospital discharge. Our telehealth model has been adapted to support the pandemic. In Wave 1, we monitored up to 5,500 patients that were clinically extremely vulnerable and screened them daily for signs and symptoms of COVID-19 that would lead to closer monitoring. This meant around 3,500 patients were onboarded across a 2 to 3 month period, but we could only do that because we had all the right foundations in place. Specifically related to COVID, we've monitored over 8,000 patients to date. 95% of all the patients monitored by the telehealth hub required no additional support. 3% went to hospital for further treatment. 2% were referred to their GP. This has had a direct impact on relieving pressure on both primary care and hospitals. But this was only possible because of the experience and skill mix within the telehealth hub. Having the right foundations in place has enabled this rapid expansion of the service. To illustrate the impact of telehealth on patients, the following is a patient story about a couple that were monitored by telehealth for COVID-19. The gentleman is Colin, a 67-year-old from Liverpool that contracted COVID in October 2020. At first, he tried to ignore his symptoms, but they quickly took hold and his condition rapidly deteriorated. He was referred to telehealth for monitoring support, and Docabo helped to set the patient up for monitoring within 24 hours. The nurses monitored his condition and spotted a significant drop in his oxygen levels that would require hospital treatment. He received antibiotics and would continue to be monitored by the telehealth team at home until he became well again. There is a great opportunity to redesign how services are delivered to make best use of the limited resources at our disposal. One of the main developments since the pandemic has been virtual wards. This has helped hospitals with their capacity and flow. An ageing population where people have more comorbidities are some of the greatest challenges that are faced by the NHS. Against a backdrop of reducing workforce and budget, telehealth can provide a solution to this. The telehealth systems, such as those provided by Docabo, can monitor large cohorts of patients with a relatively small nursing resource that has very effective outcomes, such as reducing healthcare utilisation by up to 20 to 50%.
Hello, my name is Rosie Corr and I am Clinical Lead for Telehealth for Cheshire and Merseyside, and I'm also Deputy Medical Director for Merseycare Foundation Trust. We first used the telehealth to support the patients with COVID during the first wave. During this time, the wards were filling up with patients with COVID-19 who still had ongoing respiratory and psychological needs, and we needed to get them out back into the community. So we were approached by the community respiratory team from Liverpool University Foundation Trust Hospitals who were used to using telehealth to support their patients with COPD and asthma out in the community, to find a way of supporting the patients with COVID oximetry at home. So the patients were identified and onboarded onto the telehealth hub and sent home with telehealth monitoring, both which could be monitored by the telehealth hub, but also the community respiratory team nurses were also able to review the oxygen saturations and other parameters that they were monitoring for these patients. So the patients went home with about 2 weeks of specific COVID-19 monitoring, and then if they had ongoing needs, they could be stepped down onto one of our usual pathways for long-term condition monitoring. And all in all, in the first wave, around 27 patients were discharged home sooner with this ongoing monitoring from telehealth. During the second wave, we became aware of a condition known as silent hypoxia in patients with COVID-19. We already knew that patients' saturations dropped quite dramatically and were associated with poor outcomes for patients. However, the condition of silent hypoxia really hit home as to how important it was to monitor the oxygen saturations, that is the level of oxygen in the blood for these patients. What was happening was that the patients were becoming unwell and their oxygen saturations were dropping, but patients weren't aware that their oxygen saturations were dropping. They weren't presenting with the usual symptoms such as feeling breathless or fatigued that you would normally expect at such low oxygen levels. And actually, by the time that they got to the levels of desaturation that are associated with poor outcomes, they'd actually been brought in the hospital too late into their disease journey, and therefore these patients had poorer outcomes. So the term silent hypoxia was about catching the patients as soon as they started to desaturate, i.e. their oxygen levels started to drop below a threshold at which we wanted to get them into hospital. And as you can see by these graphs, the earlier you intervene, the better the likelihood is of patients either surviving or doing well from their COVID-19. So at this time, guidance was released for the silent hypoxia pathway, which said that patients who'd been diagnosed with COVID-19 should be monitored for the 14 days of their illnesses. Because the other thing that we found was that actually they tended to do desaturate on days sort of 9 onwards, so quite often when they thought they were into the recovery phase of the illness. So guidance was given out to nationally saying that patients needed to be monitored with their oxygen saturations during this period of their illness. We were already using the telehealth platform to monitor the oxygen saturations and other parameters for patients who have been discharged out of hospital. We then pivoted that to monitor patients in the community for silent hypoxia, essentially digitising the oximetry at home pathway. The benefit of this was that patients could be risk stratified according to their risk of poor outcomes, and we could tailor the offer for telehealth and oximetry at home according to their risk. And we could also tailor it according to the level of sort of ability to patients to manage with the different elements of the telehealth system. So we first of all built up an oximetry at home pathway for patients who are being referred to primary care. But then the other benefit of having this platform is that we could then use that platform to then also take access from patients who are presenting in walk-in centres, patients who are presenting to ambulances, patients who are presenting to A&Es and who would otherwise have been admitted, but A&E felt they were comfortable to put them on the oximetry at home pathway and get them home. During the third wave, we were in a slightly different position in that we had the oximetry at home pathway set up, which was identifying people early to get them into hospitals. And we also had new treatment pathways, including dexamethasone, which enabled people to be treated early in their disease illness and reduce the number of people needing to go into ITU. However, the number of people going into hospitals were overwhelming, and our local hospitals were struggling with the capacity of managing these patients. At this point, we looked at the learning that we'd already had from the oximetry at home pathway and the first virtual ward pathway, and developed that into an early supported discharge pathway for patients who were still COVID positive and on treatment pathways, but we would replicate the monitoring that they had in the hospital in their home. The way this worked was the patients were onboarded in the hospital ward and they were identified by their respiratory physicians, and they were onboarded onto the telehealth hub platform, which is monitored by our Mersey care nurses. However, we also had oversight from our respiratory colleagues who could also view the telehealth platform, but then would hold daily ward rounds with our telehealth nurses and identify any risk factors or any need for perhaps admission back into the hospital. And then after 14 days of monitoring, again, in a similar way to the other early supported discharge pathway, the patient would be discharged back onto normal care or could be picked up by a long-term condition monitoring pathway. So the idea of this was to actually support people to be discharged out in the community earlier than they would have been without the telehealth virtual ward. So the COVID virtual ward has been shown to be safe and effective, and we can monitor multiple patients at the same time safely with specific clinical pathways. So we're now looking to develop this virtual ward model to support other areas such as respiratory patients who have either pneumonia or have had an exacerbation of COPD or an exacerbation of asthma, and getting them out of hospital sooner, and using the pathways templates that we've developed both for long-term condition monitoring but also the learning from COVID virtual ward. Another area that we're looking at developing virtual wards for is for heart failure patients, again to bring them out back into the community sooner if they've been admitted into hospital. But a virtual ward also works for preventing people going into hospital, and for patients in care homes. This is another area that we're looking at developing. The combination of using the telehealth platform with specific clinical pathways, and also the telehealth hub with the nurses who are used to acting on the alerts from the platform, and then the interface with the specialists in secondary care, either respiratory or cardiac or our geriatricians, means that we should be able to support more people at home safely using telehealth platform rather than keeping them in hospital or preventing them from going into hospital in the first place.
I hope you found the Liverpool virtual ward developments interesting. We look forward to seeing you at the ITHACA conference on the 21st of September. Where hopefully we'll be able to answer any questions you have and chat to you in a bit more detail. Until then, thank you for your attention and goodbye.